We are now going to go through protocols 25, 26, 27, and 28, but we're going to take it muscle by muscle, and we're going to look at the muscle, its referred pain, then we'll evaluate length, strength, palpation, and treatment. So that's it. Each muscle, referred pain, length, strength, palpation, and treatment. That's what you need to do as a trigger point therapist. For each of these muscles, there's a specific pattern of pain. There is a normal range of length and shortening. There is a normal response to a strength test, and there is a normal quality to the feel with your hands called palpation, a palpatory quality. And you should be able to evaluate all those and treat it to correct anything that's not doing, it's not the way it should be. Okay. All right, we're going to get started. Sharon, what's our first muscles?
Well, we're going to treat the rectus femoris, and we're going to do two tests for the rectus femoris right here.
Okay,
so here's where it's attaching onto the pelvis, and then here's where it's attaching onto the tibia. So it attaches onto the anterior inferior iliac spine, and then down here to the tibia. And of course,
baseball pain, right?
That pain in the kneecap right there. Really bad kneecap pain, deep in the kneecap. And it's L2 to L4 and it's nerve roots. And it crosses two joints. So that's why we're going to do the Thomas test. And you could also do the supine.
Prone.
Well, we're going to do the prone one, yes.
Yeah, we'll do the prone. Prone knee to buttocks.
That's what we're going to do, yeah. So because it crosses two joints.
Yeah, you have to get two joints to flex to test this range of motion.
Okay, so this is Travell and Simon's book, volume 2. And we're on page 250. And this is a well-used book here, you can see.
Yeah. If you have these charts and you want to know which test we're doing, we are doing the... They call it the hip flexors test, but it's called the Thomas test. Okay, where they lean back. We're evaluating this should be below 90, below the midline, and this should be hanging straight up and down and easily bend that way. It shouldn't be flexed out or the hip hiked up. And then we'll be doing the heel to buttocks, but we'll be doing lying on the stomach. That's the way you can flex the hip. So this would test the vastus muscles, but it doesn't test the rectus because the rectus crosses the hip. So we're doing this lying prone. So this test on your stomach, 33 on the stomach, and 31, the Thomas test. Here we go.
Okay, so here we're going to do the Thomas test. So we're going to sit right on the edge of the table, and you're going to put your hand underneath your knee there, and then you're going to assist them and come on down. And so you're going to see how does the knee fall. So this would be, she doesn't have trouble with the psoas, but she does have trouble with the rectus femoris. This is like
it should be hanging down at 90 loose.
Very positive sign that she's got real bad trouble with the rectus femoris. Okay, let's assist you getting up.
Try the other one.
Let's try the other one. So significant trouble there. Okay, so we're going to come on back. Okay, and here again, this is so it should be hanging straight down like this.
Are you sure you have a knee?
No.
Is there a joint there? Because it doesn't seem to be bending.
Okay, so that's that one. Can we check you, Kirk? Can you come on up here?
All right, get it over.
Okay, so real close to the edge, closer to the edge. Okay, so you're going to go underneath one knee. Okay, so you go ahead and you're going to take this back, and I'm going to help you. Okay, so
and so that's better.
We have two. So this one here, his rectus is okay, but this one's showing that his vastus lateralis and/or tensor fasciolata might be pulling
or
off to the
even
side.
a little bit.
It's
pulling off to the side.
To the side,
so you see how it's pulling. Yeah. Sharon, can you move a little bit?
Oh, sorry. Yeah.
So see how it's pulling to the side? I didn't see that from the other angle. Yeah. Yes, that's right. Exactly. Wow, really cool. Okay, this test shows a ton of stuff.
Okay, so we're gonna look on the other side.
And it might have been a little bit of psoas. Might have been a little psoas tight because the hip was up a little bit.
Okay, so let's go ahead and take it back.
We were asked, is it necessary to have them sit up between legs? I think it is, isn't it? To switch legs?
Yeah.
Yeah, it's usually pretty good.
Okay, so here it shows us his rectus is good, but on this side, but it's a little bit tight on his TFL and his vastus lateralis.
Yeah.
Okay. Yeah. So let's go on and take you up.
Excellent. And Kirk was recently a celebrity, so he's got to wear sunglasses now.
That's right.
Now he had Yeah, eye procedure, so he
Okay,
needs to
so
have glasses
Stephanie will
on.
do it real quick. Go ahead, real close. Let's go ahead and get underneath. Let's come on back. Okay, so here, Stephanie shows that she doesn't have rectus femoris dysfunction, and she doesn't have vastus lateralis or TFL.
Yeah. And also,
Or psoas.
Yeah, exactly. Since
She's
this drops
perfect.
below the
Stephanie's
midline,
perfect.
that psoas is good. Well, now wait a second. Just to stress the point, though,
Oh.
range of motion doesn't tell you
No.
that there's not a problem.
No,
It
that's
says
true.
one indicator is good
That's
because the ultimate indicator, which never fails, is palpation.
That's right.
Palpation is the rule. The golden rule is it
Okay,
must
so
be
this one-
smooth.
This one
Oh,
here
well,
shows
here we
that
go.
she has dysfunction in her rectus.
So
Okay.
rectus only on one side?
Yeah, rectus on the right.
Cool.
Okay, thank you, Stephanie. Okay,
Excellent.
so let's take a look at
The prone, the other way.
Let's look at the prone. So let's come on over this way. So you're gonna go ahead and lay on your tummy and put your head up here.
Okay. If you did this on your back, you'd be testing the rectus, or the vastus groups, but not the rectus.
Okay, so here we're gonna measure from the heel to the seat.
Yep.
So from her shoe to the seat.
Do you want to take my shoes off?
No, it's fine.
Yeah. So this is like 5 inches.
Yeah.
And so the pressure you give is a light pressure. So you're just putting it. You just go to where it stops
Yeah.
lightly.
Just the end range.
Yeah.
You know. It's
And
not.
this
You're
is-
not forcing it.
Yeah. So I see 6 inches.
6
And
inches.
this is the International Mild Pain Society gave this to me.
Oh. That's
Okay. And we'll do this side. And let's see from the shoe. And this is about 7 inches, between 6 and 7 inches. Okay.
great.
So we'll try again without the
Passing
without the
is
shoe.
that should
The
loosely
heel should touch the seat.
should touch the seat
The heel should
loosely
touch
and
the seat.
easily.
Want
Yeah.
me to take my shoes off?
Well, I already did the test.
Oh, okay, all right.
Okay. Okay. All right.
With or
Go
without
ahead.
shoes?
Better without the shoe. Yeah.
Better without the shoes.
Because I'm measuring the shoe.
Yeah, I guess my answer to you, questioner, is that just the palpation is the ultimate rule. You can have, you can pass tests even while having dysfunction. It's very true.
So here, again, I'm gonna like relax.
Yeah. No,
relax,
Jeff, you're right.
Breathe,
Absolutely,
breathe,
you can.
relax. Okay, so here we're gonna test here. So here we're gonna go, and that's about 6 inches. And let your hips fall down. And again. Oh, good. Thanks. Okay, so here you go. So we're going to go from the heel to the seat. So you're going to go from the heel to the sit bone. So go ahead, and that's about 7 inches.
Now, of course, there's no ruling out the vastus in this test either. I mean, the vastus
no.
are included. So,
Yeah, all of them.
Yeah.
And about 7.5 inches here.
Yeah.
Okay, so remember, 7 inches, 7.5 inches, okay?
okay. Should we do one more?
Okay, one more. Okay.
One of us had better pass. We gotta get one of us passing. This is embarrassing.
Woo!
Yeah, this is good.
Okay, so here, Stephanie from her is about
Couple or
that's
so.
2 inches.
Yeah.
2 inches on your left, okay. And on this side, oh, it's just like 1 inch here, and that's 1 inch.
Okay.
2 and 1.
Okay, great.
Making us look bad.
Okay, so we did the stretch test for that.
Okay, you guys want to see strength?
We're gonna do a strength test.
Strength
so I'm
rectus
gonna
femoris.
hold on
You
to
hold
the
this.
camera. Okay.
Here, I'll just do. Steph, would you mind? Okay.
Lay down.
Face up, please. Okay. So when we do the rectus, since it crosses both joints, we'll have the knee bent and the hip bent to 90. Okay, hold this, please. I'm going to have her push into me first. Remember, this is called conscious engagement. She pushes first. Push into my hand, please. And then I add 1, 2, 3, 4 increments of increased pressure. And that's a positive strength
Pass.
test. It's a pass. It doesn't mean she lifts 200 pounds or 300 pounds or 10 pounds. What it means is that the muscle is actively engaging. There's no inhibition stopping the muscle from firing. Okay, that's what we're doing. It should be called muscle facilitation test, but we all call it strength test, right? Muscle test. All right, keep this here, please. Push into my hand, and I'm going to add 1,
Hi, Judy.
2, 3, 4. Good. That's it. All right. Thank you very much. Those are both passes.
Pass.
Okay. So we said muscle, we said referred pain, length, strength, palpation, and treatment.
Great.
So-
Here we go.
Let's
Okay,
palpate
so-
and treat one of these babies.
Okay, come on over, Camille.
Now you want to see some fails.
Well,
Okay, so you're gonna go ahead and lay down on your back.
quads, probably something everybody has treated before. But how would Sharon treat it? How would a master body worker treat it?
Well, we treat it different ways.
Yeah.
But so sometimes we put a little heat on it, often like we do, and we look at the kneecap. Oh,
Okay.
the kneecap looks good. The kneecap's coming down. That's good. But remember, we want to look. We start at the inferior iliac spine. So let's find the superior, inferior. Then we find where it attaches onto the tibia. So here we're going to go straight down the middle,
Uh-huh.
and when we're treating it. Now, tell us. Could you tell us what happened to you? You
Okay, I had a car accident at the end of June and my knees hit the dashboard.
Yes.
Ooh,
So
sorry.
there's pain everywhere, especially the left.
So
Oh,
not on
sorry.
the outside of the knee, but the back of the knee, the outside, the
Back
inside.
of the knee,
inside of the knee?
quads, the hamstrings, under the kneecap, and the medial knee.
Okay.
Ooh,
So
sorry.
then
More on left than the right. but
more on the
both.
left than the right. Okay.
Okay.
So one way we treat it is have them lay just like this, and we could go like this, and find the top part of the muscle here, the superior part, and we're going to go straight in like we just did. So first we just touch. So we just touch, and then as soon as we feel the resistance, we go down slowly, and then we stop as soon as we feel the resistance of the taut bands.
Okay.
And then how's that feel?
It's fine.
So we'll go down a little bit more, especially since she says fine. Okay, what do you think there?
I feel that.
She feels that. So we're looking for a tight spot, and we're looking for a little bit of painful tight spot. Okay.
I think maybe before you treat the left, I might just test it because
Sure.
it might be good to see what a week looks like.
And then I feel
It
more.
sounds like it probably is going to test weak because of
So-
our reaction to the injury.
So usually, if you about a few fingers, so if you put your finger right here on the inferior iliac spine, and you go down a few fingers, about right there is
That's
where the most painful, most likely to cause under the deep knee pain, right here.
So there could be trigger points throughout the entire muscle.
That's right.
The famous one, you could say, the one that causes
The
the,
most
referred
famous
pain, is often marked by a bigger X on the charts, and that's the famous one. They usually not name them like 1 or TP1.
Now,
So,
So-
TP1 is here, and it
that's right.
causes
Right.
that
Right.
pain right
So,
there.
after you're in practice for how long do you decide to get a high-low table? What do you say, Camille?
I think I waited 10 years.
She waited 10 years. So, but
Well, they weren't around when they started.
Yeah,
Yes,
that's
right.
true.
we would have had to use a chiropractic table
yeah.
or some other kind of table. So here we're gonna put our elbow right there, and we just touch and then feel the resistance. So right there, I start to feel the resistance, and I'm gonna of the taut bands, and we're gonna come down, and we're displacing some of those painful sensitizing chemicals.
Yeah.
So substance P, tumor necrosis alpha, interleukin 1 and 6.
And some feel-good chemicals like serotonin.
That's right, serotonin, and
Yeah.
it has low pH.
And
Oh, that one I feel more.
and we're also causing a micro stretch.
That's right.
We are stretching the small myotactic units that cannot be done with a normal gross stretch. This has to be done with compression. Compression is a form of stretch.
Micro stretching,
Yes,
and then we'll macro stretch.
yes.
Often I hold the kneecap down
Hold the kneecap down.
so that I'm stretching it down. Because remember, high riding patella is the most likely cause of knee pain and precursor to a lot of knee pain and dysfunction.
Uh-huh. Leslie asked about pulling the muscle up while compressing. I'm not
That'd
sure
be
what
fine
that was.
too.
That
You
could
can
be
do
fine,
that
yeah.
too. And we'll come all the way down to right where the kneecap.
The good news is that the muscle wants to feel better, so it will respond, positively. Even if you're a bit of a hack in the beginning, it still wants to get better. So, you're doing the right stuff here, so it's going to respond.
Okay, so now you want to see Is your kneecap coming down? Oh, it's coming down. That kneecap's coming down, so that's good. So you want to, if it doesn't go this way, often the vastus is limiting it. If it doesn't go that way, the vastus medialis is limiting it. And if it doesn't come down this way, rectus or intermedius. Okay, so we just went straight down the center, but something that works really well is to also treat it while you're stretching it.
I see.
So why don't we do this one on the stretch?
Okay.
So why don't we go ahead and do the strength test on it?
Yeah,
And-
we've seen that this is weak before, so I thought I might as well just show you. So we do the exact same thing, 90 and 90. Right, here we go, 90 and 90. Camille, you push into my hand first, push, then I add 1, 2, and then by the time I start adding 3 increments of pressure, the muscle, it gives, which means that the nervous system is saying, I don't want to contract this muscle. And so we need to go to the, Golgi tendon organs, maybe at the origin and insertion, or maybe the spindle cells all throughout the belly of the muscle, or even just trigger points that are sending ouchie signals to the spinal cord that's shutting the muscle off. So we'll treat the muscle and see if the nervous system says, oh, okay, fine then. All right, we want
Okay.
the nervous system to say, yes, contract.
All right, so we're going to take, now this time, Camille, we're going to treat it while we're stretching it. So you can scoot all the way down to the end of the table over here. Coming down. You can put your foot on there.
There you go.
You get really close to the edge.
A master body worker would remember to use heat. A master body worker would use elbows instead of killing their hands. And a master body worker would also treat on the stretch. So those are 3 things.
Okay, so I'm going to have you go ahead and lean backwards, see if we can get you comfortable. What do you think?
That's okay.
Adequate? Sure. Okay, good. Okay, so let's make it, let's take the table down just a hair.
So you see how Sharon is heating up the next part of the body while she's working on one part. That's frequent. I see her doing that all the time.
That's common. Okay, so here we're going to take a look at the rectus here. So we're going to go right. Oh, now we put it on the stretch, and boy, you feel the top bands stick out now.
Yeah.
Now we feel.
Pop right out at you.
Woo! They're popping right out. Okay. Okay. And also, I can feel the adductor longus and brevis are sticking out as well. So we're going to go ahead and treat it while we're stretching it. So I'm going to feel the superior ankle, the superior iliac spine. Then go to the inferior one right there. So we'll start right at the attachment onto the bone.
Yeah, that's where the Golgi tendon organs, or the GTOs, are. They're the ones that shut a muscle off if there's too much rapid stretch, like maybe a stretch from being, hitting a dashboard or something like
So you
that.
can, yeah, something like that.
Something like that.
Something like that.
I don't
Okay.
recommend that.
Yeah.
So here I can really feel some taut bands
Yes,
here with
I
my
know,
elbow.
that's
So my
fine.
elbow is evaluating.
Camille's feet are resting on something high enough so that the 90-90 is achieved there. That
So
90.
you can really feel the taut bands sticking out. So you know which ones are dysfunctional.
Once she gets off the tendon, well, then there are spindle cells that could cause the muscle not to fire, and then any muscle, any nerve in the muscle that is relaying pain information will cause muscle inhibition. In fact, a neat trick is if you've got someone's muscle, and I taught my son this. This is a funny story. My son wanted to beat everybody at arm wrestling, so I taught him how to pinch the other guy's bicep really hard, and that pain response causes it to neurologically shut off for about 12 to 20 seconds.
So is that fair?
Well, well, no, I told him he wasn't allowed to win money that way.
Okay. He can just show off now.
Yeah. But he did it. So he pretended to check the other guy's bicep out, and he would pinch it, go, ooh, nice bicep, and he'd pinch it hard, and the guy go, ow.
Oh,
And then,
that was a good
all
one.
right, go. And then that pain signal inhibits the muscle. So muscle contraction.
So give it a nice stretch
There we go.
and a little massage. And I feel a lot of tension here closer
Yes.
to the knee.
Yes.
So I'm just going to come look at that a little bit more. So I can feel the taut bands sticking out right here and right above the knee, and both the rectus, the vastus lateralis, and the medialis. So I'm going to take a look, treat all of them at the same time.
With Camille, we had found that the nerve roots were quite in need of treatment as well.
Let's
so.
treat those also with her laying
1, 2.
supine. Yeah.
Okay, all right.
I'll do that.
All right.
And let's come down let's take a look at the knee itself here.
Yeah, Sharon is great at understanding and teaching that ligaments and tendons are very rich in nerve tissue too. They send signals. Even the periosteum around the bone is rich in nerves. Oh my gosh. So your brain is receiving so much, your spinal cord and brain are receiving so much information from the periosteum, the little saran wrap that covers all bones. So it's really important. She fixed a very bad problem in my mid-back by working on the periosteum in my thoracic vertebra, which I couldn't even believe it was, you know, okay to treat it. I mean, pushing on bone doesn't sound normal, but it literally fixed it. It was so excruciating, and eventually it just gave in and stopped being excruciating, and literally I never got the pain back. Where I'd had repeated treatments over and over and over, which temporarily helped it, but no one had gone to the part that hurt the most and said, "You should not be screaming." Silence. She silenced the angry nerves in my periosteum.
So one of my friends I hadn't seen in 60 years, what she said, she says, well, I met my friend after 60 years, and I had pain when I sat down, and then Sharon reached around behind me and looked at my spine, and she said, after many years of going to PT, she failed PT many times. One pressing on her back there fixed her back pain and her hip pain.
Yeah.
And all I did was reach around there and look at that spinal root.
And you know, it's not that they don't get attention, these parts of the body. A lot of people do get body work done, but it's that going to the areas where the nerves are screaming and pushing into that screaming area and silencing it and showing it how to function. Most people are they don't know that it's okay to do that. They're not brave enough or haven't been encouraged enough to have the confidence to do it. So the other and probably most important factor that a master body worker has is confidence. Yeah, and core, absolutely. Confidence to go and work on the area, to believe in the body. That's just a heating pad, yeah. To believe that the body can heal, the confidence to believe it can heal, the confidence to know that everything you're doing can only help, the confidence to coach the patient through things that may be painful in order to get to the other side and regain function. It's a lot of the game is confidence. Confidence to make mistakes and be all right with that, and know that that's just more information. Mistakes are as an evaluation tool. It's all right. What modality is this? I don't know. Petrissage.
Okay, so here we're going to go ahead and treat with, so we like to use all kinds of spa techniques as well as compression. So I like to use a lot of different spa techniques as well as and massage techniques along with the compression.
Yeah.
So here I'm going to go ahead and look at the patella tendon again. So here I'm finding the patella and then finding the tibia, and I'm going to work right there, right on the tendon.
Yeah, right. And again, not a place that's very comfortable to push on, and maybe not something most people would go to, but it's rich in nerves, guys. There is nerves in here. Those nerves are controlling. You know, people ask, okay, chiropractors say that spine controls all disease because, you know, the nerves go to all parts of the body. But then the question was asked, well, what affects the nerves? And the answer is
the muscles.
Environment, feedback from all the nerves that are richly endowed in your muscles and ligaments and tendons and periosteum. The nervous system isn't controlling like a master over a slave. It's actually taking orders from the peripheral tissues, sending information in. So, you know.
So let's take a look at the nerve root for the rectus femoris. So let's look at L2, L3, L4. Okay.
Yeah.
So
great.
So for that, I'm gonna bend her knee. I'm gonna come underneath. I'm gonna feel L5. I'm going up to L4 right there. So I'm gonna find the spine, spinous process, and then I'm find the transverse, and go right between, press towards the spinous process.
Are you using knuckles or are you
No,
using
I'm using
fingers?
my fingers.
Fingers,
so I'm
okay.
liking, those of you who have taken Jin Shin Do, this is a Jin Shin Do technique where you're pressing up and into the tissue like that.
Great, okay.
So we're going up like that. So then I'm just noticing how easy it is for us to move. So here
you guys are too funny.
Okay, so here we go. So I'm pressing right in. I'm stretching it a little bit while I'm pressing into it.
Yeah.
And I'm coming down here to L5, L4, L3, L2. Okay, push towards me and relax. And push towards me. Good. Okay, let's take a look at the other side.
Does that feel good?
Mm-hmm.
Oh yeah.
Okay, let's take a look at this side. Again, I'll start at L5.
If she's incorporating range of motion here, she's got the rectus stretching and flexing, over one joint. It's shortening, one joint is lengthening, but she's getting movement in there while she's working on the nerve roots that feed all the muscles and joints in that area.
So this would be L4, L3, and L2.
Yeah. Those of you that get this done, you know that this is some of the best stuff in life right here.
Okay, good. Okay, so if I could have you scoot back onto on the table. I can help you if you like. Okay, scoot. So if you could go scoot back up. Yeah. Okay, go ahead and lay on your tummy.
Yeah, laughing at yourself is one of my main therapies, actually.
Take this off.
Sharon laughs all the time.
Oh, I do.
Yes, we are in the laminar groove, exactly. In the
Yes,
paraspinals.
correct.
Yes, she's coming up and she's going toward the spinous process, and then she's going out toward the transverse process, then in toward the spinous and out towards the transverse.
So in this position here, so this is another way to do it. So here's L5, L4, L2. So again, here's the spine, and there's the transverse, and we're going to get right in between. So we're going to go like this, put our little pointy part of our elbow there. We're going to press in, go towards the spinous process, then towards the transverse process. How's that feel?
Fine.
What?
I feel a little bit, but
feel a little bit.
okay.
Fine is not that descriptive.
It's okay. We like what you said.
All right.
It feels
Like
good.
fine.
Feels good. Okay.
We
So
like fine. Okay, and then we'll go on the other side. So here's our L5, 4, 3, 2, right there. So let's come right there. So I'm going to lean over and press in and towards the transverse and towards the spinous. Come up a little bit. Towards the transverse, towards the spinous.
CA channel back up and running.
So what you want to do to see if you've improved it is you want to see if you can do a good job of skin rolling. So wherever you didn't get a good skin roll, like about right here, then maybe I'll do a little bit more. Okay,
Yes.
so I'm going to go back there and see if I can get a little bit better.
Yeah, absolutely. Skin rolling. It is the manual. It's the manual EMG
That's
technique.
it. That's it. The manual EMG.
When you're rolling that skin tissue, you are assessing, in a way, how much tension is coming from nerve impingements in those areas.
So here it's pretty good, and it could be just a little better right here. So here we go. I would probably do this side from your side, but I thought
Yes, yeah.
I thought I would just do it so you could see it better.
You always have to
Okay.
respect the camera.
Okay. So we could get this a little bit better.
Yeah, you know, you could spend lots of time, and Sharon has showed you how you could do it on the stretch.
So you want to keep seeing, you can keep treating it and see if you can get that skin to really lift up more and more.
Yeah.
So right here, it's lifting up pretty good, but it could lift up a little bit
Yeah,
better.
she could have her legs off the table, be bent over the table, and she could have one shoulder tucked under, one arm tucked under while she's rotating. So that could be good for
Go
stretch.
ahead and press your foot towards me, and then relax. And press it towards me, and relax. Let's go, and press, and press. Good. So here we have about, let's see how many inches. We'll see how good we did. So before we were like 7.5. It was a little hard with the
I think
shoes.
we were 6
Well,
on
here-
this one and 7
Yeah.
on the other.
Here, well, it was the shoes. It was pretty.
The
So
shoes
anyways,
were about
5.
an inch, yeah.
Okay.
Okay, and then on this side, let's see how we did. So here, let's go a little bit stretch, push, and relax, and push, and relax, and push. Good. So we give it a little extra stretch there. And then, so again, with the test, you're just going to go to where it stops, and then we're going to test it here. And this is like 5.5 inches. Okay.
But don't forget that the vastus are involved in that test.
Oh, also,
And we haven't treated the vastus yet.
but
So.
in addition, Justin,
Oh,
one
yeah.
more thing
One thing.
is that if the hamstrings won't contract,
Yeah, they won't shorten.
then it will also, so everything will, it's
Yeah.
really testing a lot of things.
Yeah.
But again,
Yeah.
so we're looking for this to really,
Yeah.
the heel should touch the seat.
Yeah.
Okay?
Yep.
So we still have some more things to treat.
Yeah.
Okay, so let's take a look at you, let's do your strength test one more time. Let's try that.
Yeah, let's try the strength test one more time as well.
Yeah.
You turn over.
On your
Yeah.
back, please. So for the rectus femoris, we need to test the hip and the knee joint at the same time. So we bring it to 90 and 90. Okay. You push into my hand first, and I add 1, 2, 3, 4. Okay, so we improved the rectus
Yes.
femoris strength test. So we got one sign of good.
You did it. You did it.
Yes,
Yeah.
fantastic.
Yeah.
Okay,
Good.
so someone said, what if you had a torn
Well,
meniscus?
yeah, we could try this one.
See
Well, a
what this
torn
one
meniscus
says.
might send impingement, but mostly we like to fix things that are treatable. So what if it was a tear in the meniscus and the whole knee was weak? Well, we treated the muscles and the knee got strong, and then the meniscus healed faster. Then
Well-
and the person moved without pain. Then we could probably say, well, that tear is probably going to heal and be all right. Doesn't necessarily mean you have to immediately go in and fix the meniscus. You could.
Well, we could look at our results
Yeah, look at
and
our
see.
results.
Now, what if the torn meniscus was causing none of the person's complaint?
Right. And
So
what-
maybe the soft tissue treatment will help them a lot, or maybe they'll still need some assistance with that.
Totally. All right, just like this, 90-90, push up into my hand. Then I add 1, 2, 3, 4, 5. Good.
Well, that's
All right.
strong.
Yay!
I passed.
Hey, she
Yay,
passed.
passed.
Okay.
Okay, you passed the strength test, which was good, so that we know that we
Yes.
improved it.
Yes.
So that was great. So super great.
Fantastic.
Okay, so let's. Why don't you go roll over and go ahead and sit up and then stand up. And shall I lower the table down a little bit?
Oh, how
for you?
bad was her Thomas test?
Oh, we could test the
Because
test.
the Thomas was more for the
All
rect,
right,
more for the,
well, it was.
Yeah.
Okay, let's check it. Let's do it.
Back to
Let's
Thomas.
we're gonna do the table.
because the heel to buttocks could be a problem with the vastus still.
That's true.
But,
That's true.
but
The table lower?
Let's make it a little lower.
remember how her leg just kind of stuck straight out on the Thomas test. So let's see if we improve that at all. And Sharon will show you how she might treat it in this position too. You might.
It's a little high step.
Oh, still.
Yeah.
Here we go.
Short.
Okay.
That's
Okay.
right. Okay.
All right. Okay, go sit on it a little bit. Okay, and then you could put your hand underneath, and you're gonna bring it back. Okay, and let's see how we do. Okay, so there you go. So
That
I
is
would
a
say
little better.
A little bit better.
I'd say it's
Mhm.
about 50% more than it was, 30 to 40% more than it was.
Yep.
And you could always
Try the other one.
almost treat in that position to increase the range of motion too. You could,
Yep.
Yeah.
So
so
you hold it there.
yeah.
So,
So
one
she
thing
could
we could do
Yeah.
is we could treat it right. So we're trying to always get you to pass the range of motion test.
exactly.
So we can go ahead and treat it while we're stretching it.
Yeah.
So I'll help you hold it up.
There we go. Yeah.
That's a good spot.
This is one of the main spots that causes the knee pain.
Yeah.
So you can see what makes it better.
So what we're learning from this is that getting the rectus in a really good stretch, and this Sharon is always saying this, really maximize the stretch when you do the trigger points. You will have such a greater effect than just treating in a neutral or slightly stretched position. So the lying in the stomach with the knee flexed is a good stretch, but look at this. This is a very effective stretch for the rectus. And she's getting some real, you can already see the improvements as she's working on it. It is just loosening up and lowering and relaxing. So sometimes it's about getting the right stretch while you're treating. Yeah, you can see, look at it giving in and just loosening up there.
Okay, let's see how we did.
Oh, look at that! See,
That's
a ton
almost
better.
closer to
Almost
pass
close to a
there.
pass.
Mhm,
Very
almost
good,
close to
very
a
good.
pass.
And then
Mhm.
good, yeah.
Okay, here we go. So we're going to take a look at it a little bit while we're stretching it.
If the patient's having trouble, I have often had times allowed them to put their heel on my shoulder or something to give them a little stability. But what a great position, right?
Mm-hmm.
Yeah, there you go. Good. Now, an interesting point here is that this is a simulated gait position. So, not to go too far into it, but the Masters course, you treat in a position of gait. So I was taught to treat people while walking with one leg forward. So put them in a position of walking with their right leg forward, which means their right arm is back and their left leg is back, and the right leg and left arm are forward. Put them in that position, treat the muscles in that position. So the idea here is look at how we're treating her in a gait position. This looks like she's about to jump over what are those things in the Olympic races?
Hurdle?
A hurdle, yeah. She's about to jump over a hurdle. And the rectus femoris is not working in that position.
Okay, let's see how we did. Good. Okay, go ahead and press your ankle towards me. Push. And relax.